Hello, everyone. Welcome. It is now 12, so we're going to go ahead and begin this session. Thank you so much for joining us today. Welcome to the sixth session of our fourth series of the PPCL Pediatric Mental Health Tele-Echo program. I'm Jody West, and I'm the coordinator for today's session, and I'm also going to serve as the facilitator. Dr. Olivier is out this week, so I'm going to go over a few housekeeping items before we begin. This is our agenda. We're going to go adhere to it the best we can. Then I will lead us to introductions and tell you a little bit about PPCL, which is the program that hosts the ECHO. Then Ashley Hutchins is going to present both the didactic and the case presentation. And then after the case presentation, we'll move to clarifying questions. First, we'd like to really focus on the participants and then the hub team. And then once all the questions have been answered, we'll transition to providing recommendations. All recommendations will be sent out, so we just want to encourage everyone to participate and have the dialogue. Sorry about the format of this slide, but we're going to do our best to stick to this timeline. If you can, please come on camera. If not, just enter any questions in the chat or raise your hand and we can get to them at that point. So just some brief introductions. Like I said, I'm Jody West. I'm also the program manager for the provider-to-provider consultation line, as well as the ECHO coordinator. A little bit about PPCL. We provide mental health consultation to healthcare providers across the state of Louisiana. Today, our ECHO is focused on pediatric, which is 0 to 21. And so education is part of the program, part of the services that PPCL provides. But we also do consultation. So at any time, if you have a case like what Ashley's going to present, or you have a patient or client that you're having some challenges with, you'd like resource information in your area, would like to speak to a psychiatrist about medication or diagnostic questions, you can give us a call and we can help support you in finding the resources that you can then give to your patient or client. I'm going to leave this slide up, but I'm going to go ahead and ask the rest of the hub team to introduce themselves. I'm going to ask Ashley to introduce herself first, please.
Hi, my name is Ashley Hutchins. I'm a psychiatric nurse practitioner. I work at Bloom Mental Wellness here in Lafayette, Louisiana.
Thank you, Ashley. Lena?
Hi, everybody. My name is Lena Reguette. I'm a LCSW, also one of the mental health consultants for PPCL, and I help with IT support for the ECHOs.
And then Dr. Cocky.
Hi, everybody. I'm Dr. Cocky. I'm a general pediatrician in Broussard, Louisiana. So I'll hopefully be able to provide some of the pediatric perspective on our 19-year-old case today, but I'll do my best.
Thank you so much. And just a reminder, pediatrics is 0 to 21. So I think it's going to be a great example for us to discuss instead of it being, a middle childhood or early childhood. This is an interesting case with in later adolescence. So, but now we're going to go ahead and transition to the didactic presentation. Ashley is going to lead us in that. Ashley, just give me a verbal cue when you'd like for me to promote the slides, please.
Okay, sounds good. So yes, I'm doing the didactic and the case presentation. So you're going to be hearing my voice a lot today. So to get started, our didactic is going to be on non-suicidal self-injurious behavior in pediatric patients. Next slide. These are our objectives. I'm not going to go through them for the sake of time, but we're going to kind of touch all the bases of background, treatment, assessment, etc., on how to deal with this if it presents in your setting. Next slide. Okay, so non-suicidal self-injurious behavior. The definition of this is an intentional destruction of body tissue without the intent to die. So examples: cutting, burning, scratching, biting, hitting oneself, hitting objects until they physically injure themselves. And we typically see this type of behavior between the ages of 12 and 14, but it can start earlier, rarely as young as 5 to 7. It's estimated that approximately 17 to 18% of the general adolescent population will have at least one episode of non-suicidal self-harm behavior. And research has shown mixed results regarding the prevalence in males versus females. But what research has shown is that the likelihood of non-suicidal self-injury is 6 times greater among LGBTQ adolescents than heterosexual youth. Next slide. So we see this behavior commonly in clients that have anxiety, depression, PTSD, eating disorders, and personality disorders. Studies have shown that adolescents who engage in non-suicidal self-harm are 3 to 7 times more likely to have a suicide attempt in their lifetime. And some risk factors that have been attributed to self-harm include having a history of adverse childhood events, substance abuse, issues with impulsivity, bullying, sleep disturbances, dysfunctional family dynamics, parental psychopathology. And then a big one that I see a lot is exposure to peers who engage in this self-harming behavior. It can influence them as well. Next slide. Okay, so why do they do this? Okay, so what has been reported most often is that the self-harming behavior serves to regulate or manage negative emotions. The pathogenesis of repeated non-suicidal self-injury may perhaps involve endogenous opioids, but evidence of serotonergic and dopaminergic dysfunction is less consistent with the research that has been done. The most widely studied psychologic factors related to non-suicidal self-harm are the functions or the motivations that maintain and may also cause that behavior. So examples, self-harm may serve as like a release from negative emotions. It may actually induce a pleasant state for them. It may serve to get attention, but we need to understand why they're seeking it in that way. It may facilitate an escape from undesirable situations. They don't have to necessarily go to school, et cetera, if that happens. Sometimes it serves as a form of self-punishment. Like I mentioned before, it can also be influenced by peers, music, and social media. Next slide. So some warning signs to look out for if, they suddenly start having frequent unexplained injuries or marks to their body parts that they say are an accident or they don't know how that happened. Also an unusual way of dressing, which also this is kind of the fashion now, but like multiple bracelets, long sleeves in warm weather, refusal to participate in activities that require a certain dress code like swimming or a gym class. And so when you're interviewing a patient that you suspect is engaging in these behaviors, you want to interview the patient and caregivers both separately and together, ideally. And it's encouraged to bring up the topic rather than wait for self-reporting, because a lot of times they won't self-report. So specific questions that you can ask would be like, have you ever done anything to purposefully hurt yourself without trying to die, such as cutting or burning yourself? If patients endorse those self-harm thoughts and behaviors, you want to ask further clarification questions to make sure that there is a suicidal intent behind it, or if it's non-suicidal or mixed. When you're asking these questions, we have to be mindful of our tone. We need to convey concern and empathy and try our best to avoid judgmental and negative reactions so that they'll feel comfortable developing that rapport with you. Next slide. So you want to determine the following. Okay, onset. When did this start? Past occurrent frequency. How often has this happened in the past, like the past month and year? When was the worst period of time that it was happening? And has the frequency of the behavior, has it increased, decreased, stay the same over the past year? You also want to know their methods that they use. So what objects have they used and how have they inflicted self-harm? They can get pretty creative with this. Do they use razors, lighters, erasers? Do they use their own nails, etc.? And then, of course, you want to address the severity. How deep do they cut? And how do they care for their wounds after they inflict them? And have they ever needed medical attention for a self-inflicted wound? You want to ask where on their body do they self-injure? And then also, how long do these periods last? You can perform a skin check in your office. Most common areas that self-injury occurs are wrists, arms, upper thighs. It can occur anywhere on the body though. And if they do have those injuries, of course, you want to assess the wounds for signs of infection. Next slide. Okay, here's a big one. So confidentiality. Patients may be reluctant to disclose self-injurious behavior out of concern that this information is going to be shared with their parents or guardians. So there's factors to consider when disclosing this kind of information. So like we mentioned, how frequent is it? What methods are they using? How severe has the cutting got? How much distress is driving that behavior? And the degree of functional impairment. Are they not able to cope with the daily stressors of life? And of course, presence of psychopathology, suicidal ideation, and or suicidal behavior. Next slide. Okay, so this is an example of a case where you do not necessarily have to disclose self-harm to a parent. Of course, it is always up to your clinical judgment. And in a primary care setting, I can understand rather, being safe than sorry. But some of the discretion that we use would be an example like if a child has engaged in that self-harm maybe once or twice, used one single method that resulted in a superficial wound that did not require medical attention, and they're actively denying suicidal thoughts or behaviors. However, if this self-harming behavior occurs frequently, if it's increasing in severity, if it's co-occurring with suicidal thoughts and behaviors, you should definitely inform the patient to maintain that safety. So to maintain rapport, if you feel like, okay, I got to tell their parents, how can we develop a rapport? We want to give them some role in this. So you can give them some options to choose from regarding how you're going to discuss this with their parents. So you can give them the option saying like, I can tell the parent privately and I'll explain what I'm going to say to them. Or I can tell the parent with you present, and that way you can clarify anything in case I misspeak. Or I can be present while you explain to your parent what has been going on. It gives them a little more autonomy in that. Next slide. So treatment. Outpatient psychotherapy and medication management is appropriate for adolescents who are not at a moderate or high risk for suicide. So the first line treatment is DBT, dialectical behavioral therapy, adapted for adolescents. Second line would be cognitive behavioral therapy. Third line would be an alternative form of therapy, family therapy, psychodynamic psychotherapy, etc. And then SSRIs, SNRIs, atypical antipsychotics, they're indicated for underlying mood disorders, but the research shows that the therapies are the most effective intervention. In fact, for me, in my practice, if I have somebody coming in with cutting, that is a contingency. You have to go to counseling to start figuring out what's driving these behaviors and how can we modify them and hopefully extinguish them in the future. Next slide. Okay, so treatment is indicated for multiple episodes of self-injurious behavior if the self-harm is being used to cope with underlying distress and or if self-injurious behavior requires medical attention like sutures. Inpatient hospitalization may be required for adolescents who cause severe bodily harm to themselves, and if they cannot be adequately monitored at home, and if it's present at the same time with symptoms of agitation, aggression, or psychosis, this puts them at a higher risk of doing more harm. When you're determining that level of care for adolescents engaging in this self-harm behavior, you want to ensure safety, but you also, if possible, you want to maintain that highest level of functioning in school, social, and family domains. So if they have a counselor, if you have a referral source where they can get in with psychiatry sooner, take all those factors into consideration instead of isolating them. But sometimes inpatient is the best way to go to get them stable and then move from there. Next slide. Okay, parent education. So you want to collaborate with the child and their parents to create a safety plan where they identify warning signs and triggers. You identify coping strategies, activities that can help them relax, distract themselves, exercising, listening to music, writing a journal. And then you want to also, strategies can include changing their environment to be around people and to go to places that provide a distraction. They do not have to tell those people that they're having that urge to self-injure. It could just be a positive distraction for them without the intent of discussing what is the underlying feeling. And then they need to identify human resources that they can use when they feel unsafe. So that could be family, friends, mental health services. And it's important to keep the environment safe. You want to get rid of any instruments that they might use to self-injure. Next slide. So this is an example of a safety plan. It kind of goes through everything that we just mentioned. And then at the bottom, I like, it lists professionals that can help. Of course, 988 is always a good option. We've talked about the extra mile as well. So those crisis interventions, if needed, are good to include. Next slide. Okay, so you want to educate parents that many children who engage in self-harm behaviors, they're not likely to abruptly stop it. Recovery is a process. Relapse is the name of the game with this condition. And so you want to also educate them on warning signs. So kind of like what we talked about before, they can look for those unexplained cuts, marks on the bodies. Pay attention to see if their child's covering their skin with sweatshirts, even in hot weather, the excessive bracelets, avoiding those activities like swimming. They can kind of keep an eye to see if they find bloody tissues in the trash bin. Another intervention that I like at home that could be helpful, they can perform what we call random skin checks. So you can take a jar and put the numbers 1 through 5, and every day you have to pick a number, and you guys would decide, like, say every day you pick a 2, we're going to do a full body skin check. And then really in therapy is where they would come up with, okay, are we going to have consequences? How are we going to work with this when a relapse does occur? Also, they can perform room checks where they look, under the mattress, in little hiding spots. They're wanting to look for any sort of sharps, any instrument that they can use to hurt themselves. And you can also institute like where they have to come to you to get the razor to shave and give it back to you after they're done. And then how we mentioned how peers, social media, music, all of that can influence kids because they're trying to figure out that identity. And unfortunately, sometimes they latch on to some of these unhealthier habits. So parental controls, surveillance, and limited of social media use are imperative. You could also have the client keep a journal or a log of the thoughts, behavior, urges, triggers, consequences, and also have them track like the days that they're successful at not cutting. That's important. Help them find those wins. Of course, this will be further addressed in counseling, but this is just some helpful upfront information that you can give to parents. Next slide. Okay, so I included all of these, some websites, some books, and then at the bottom, there is an app that I've used with clients. It's called Calm Harm. It's free and it kind of tracks and can help them resist urges for self-harm and then track their progress because it's important to take the small wins. And if they do have a relapse, it doesn't mean we're back at 1. We need to give them that positive reinforcement for the being able to abstain from that behavior when they can. Next slide. That's it. Okay. Does anybody have any questions for me? I talk fast.
I do have a good question for you, Miss Ashley. What do we do about skincare afterwards? I feel like a lot of the healing process is that we're still covering, that we're still hiding it, like the evidence, the scarring. And if they don't want to see dermatology, for example, because then that's just another person who knows. But any good skincare tips for trying to help these scars heal?
Of course, I understand when they're at school and in public, I understand wanting to cover that, not draw attention to it. If at all possible at home, I've also had them say like sometimes the scars remind them and can trigger them to do it again. It's really, what if, actively healing, of course, you want to make sure that you're using antibiotics. And then I guess, that would be from a pediatric standpoint, if there are those, Mederma is over the counter, but like tretinoin, those kind of things to fade the scars. If they are actively like saying these scars are bothering me, they're not healing, it's causing an issue, any sort of distress, then that's where I would think go into that next. Okay, let's see what interventions we can do to prevent it. But hopefully, they're young. Hopefully, if it's not too deep, that collagen will do its job and it'll heal with minimal fading, minimal scarring.
It's been my experience that a lot of times the parents want to hide the evidence versus
Yeah.
then the child's not so bothered by it. And it might serve as a reminder for the child of past behavior and not necessarily trigger in a bad way, but just as a reminder that, look, I survived this or I made it through this. So
Yeah.
sometimes you have to say, is it bothering the child or the caregiver?
That's a good
Um,
point, Jody. Yes, I've had, yeah, where it's like, I'm not going back to that. Yeah, I've had that too in my experience.
And something I used to suggest, so I worked in school systems for a long time and, that middle school age. When I would work with parents would be that if there's an occurrence, if there's fresh injuries and it's not infected, but it needs it needs attention, it needs washing, it needs cleaning, it needs bandaging, that's something the child goes and does on their own, because then that parent helping the child with that, there's a bonding moment there, there's caregiving, we don't want to reinforce the behavior with connection. So it's real important to kind of allow the child to deal with the consequence in cleaning and in bandaging, and then try to build a connection outside of the caring for the injury they created. So it's not linked to attention seeking, because a lot of times I find it's not attention seeking at first, but it can
Yeah.
get there.
Yeah, there can be some secondary gain associated with it, but that's where,
course.
I have a lot of parents like, oh, it's just for attention. It's like, okay, well, hold on. Let's try to understand what's driving that. Where's the need? What's coming into play? So yeah, that's a very good point.
We have about 2 more minutes. Any other questions about for Ashley about the topic for the didactic?
I have a question. It's kind of off the wall, but have you seen any research looking at the supplement N-acetylcysteine? I have a hard time saying it's a stroke.
NAC, yeah.
Yeah, for helping with this particular. I've seen it work for skin picking, hair pulling, nail biting, but I don't know if it's been studied with self-injurious behavior.
So yeah, there's some mixed research. Some has shown that it can be helpful, others not so much. N-acetylcysteine has been looked into in addition to that naltrexone, because there is that endogenous opioid release. But as far as, NAC is over the counter, it would not hurt to try, but results vary. And then naltrexone, I've seen it prescribed whenever I used to work inpatient. But you're not going to get insurance to cover that for a child and for, any use other than the alcohol withdrawal. And it's also mixed. And, I hate to say it, but with kids too, sometimes there is kind of like that placebo effect. Like, okay, this is going to help me. Like, so sometimes, to me, that NAC, it doesn't hurt to try. But the research is pretty mixed on it.
Okay, thank you.
I had a question. So do you sorry, my video, but do you end up telling them early on or wait for the therapist about like using the rubber band on the wrist or other type of maneuvers when they're having those urges to prevent true self-harm, but then still providing kind of that stimulation that they're looking for?
I'll give them some suggestions to try, like that. Yeah, like it's the rubber bands. There's some ice cube where that sensation can also help sometimes. I'll give them some suggestions, but I also, say I want you to explore that with therapy. Like, how effective is it really? If it's not effective at all, what other input could help us, extinguish that need, that drive. So I do mention it, but absolutely how effective it is, that's something where therapy would come in to play more. But that's why it's just so impaired to me. Like, when I first started my practice, I'd have some come in, they didn't want to go to therapy. Now it is across the board. If I'm treating you for self-harm, part of my treatment plan is going to therapy. And if you're not going to be compliant, there's not much I can treat the underlying anxiety, et cetera. But that self-harm behavior, we really need to dig deeper to find that the functions, the motivations, and be able to heal from that, and the cognitive distortions that come with it.
Okay, well, thank you, Ashley, so much for your presentation. And just a reminder, we will send the slides to everyone, so you'll have access to the resources and the research that Ashley is just make some wrap up and announcements. Lena's going to put the CEU survey in the chat, but I'll also send it out by tomorrow, an email if you need CEUs. Our next session is on Tuesday, August 12th And we do need a case presenter. So if you have a case that you'd like to bring, please let us know. Just email us and we'll help walk you through filling out the form, and we'll be here to support you during the presentation. And just as Ashley effortlessly did. But our next session is going to focus on grief and loss, and Dr. Mayer is going to present. So we appreciate your time and attendance. As soon as we end our session, we'll submit it to upload on our website, the didactic portion. So if you have someone you might want to recommend to watch it, it'll be available on the PPCL website. But thanks everyone for your attendance. Thank you, Ashley, for all of your time and information today. And I hope everybody has a good afternoon.